Hello, my name is David O'Regan. I am a consultant cardiac surgeon in Leeds Teaching Hospital Trust in West Yorkshire. I'd like to chat to you about my philosophy on delivery of healthcare as a consultant and more recently having experienced it as a patient. I've often asked students, medical students and business students, what they regard as the operative word in the term National Health Service. To my mind, the operative word is service. Now, I think this is an important principle, fundamentally because you and I have not met, but we're both customers in our everyday life. We go to restaurants, supermarkets, banks, and we expect a service. We also would have no hesitation whatsoever identifying what is good service and what is bad service. So what gets me is, why can't we bring that expectation and principle to work in what we are doing in our daily practice? And I'd like to expand on this further. Firstly, the medical profession, or delivery of healthcare, is defined in the Oxford English Dictionary as probably the most true service-based profession. We're here to care for people. With that comes a lot of important principles. We should be treating patients as we would expect to be treated as customers all the time. Now, this is not just the encounter with a doctor or a nurse, but it's the encounters with everybody within the hospital that count. And I reflect on my experience going through and having surgery on my neck recently, that the ODP in theatre on induction held my hand. And to my mind, this reinforced the important principle of touch and caring. I am a surgeon. I wasn't scared about the operation, but that simple act of kindness meant a lot. Likewise, I have accompanied staff on invasive investigations because they've been scared and worried. And what is not good on the receiving end of this care is to arrive at a desk, there's no meet and greet, there's no smile, there's no look up, and then you kept waiting and waiting and waiting. And the communication at that level is poor. I reflect on my experience recently in the hospital, that the staff were very good with "hello, my name is," and "what do you like to be referred as? My first name or Mr. O'Regan?" Nobody, fortunately, actually changed the tone in their voice into a condescending there, dearie, okay, sweetheart, which you wouldn't get if you went to the supermarket or to see a bank manager. But it's every encounter that counts. And I reflect on the company in the world that focuses their attention on experience is Disney. And some time ago, one of my registrars working on the firm had a summer job as Goofy in Disneyland in Orange County in Los Angeles. And he told me that all the staff were actually trained how to speak and how to interact with their customers. In fact, every industry that's involved in delivering a service trains their staff how to interact and actually gives them a script. This, I think, is important for answering the telephone, for porters taking you as patients to various parts of the hospital, to the hotel staff serving meals. All of that adds to the experience. Complaints don't come because of a poor clinical experience, but they usually come because people do not feel they've been heard or listened to. So the simple principle of service and what it means to you and me as a customer in everyday life, I think is important to how we deliver our healthcare. And that is determined by your own values. Now, everybody talks about changing the culture around here. So how do you change the culture, and what does culture mean? Well, some time ago, I actually contacted Edgar Schein, who is the culture guru, to ask him, what do you mean by culture? And he came up with a very simple answer. Attitudes plus behavior equals culture. A plus B equals C. And this resonated because we hire attitude and we should be coaching behavior. And in particularly in the climate in which we work, bullying is cited in many examples of failure of the system, and that is behavior. The next important principle of a service is data. Now, it's interesting when you go to a restaurant or a hotel, all that data is immediately collected at point of service on a handheld terminal that gets fed back to the central office. And there are restaurants that can determine exactly how to decorate the restaurant for a particular part of the country and how many shrimps to order in 2 seasons ahead for their shrimp cocktails in the restaurant. Just imagine if we applied that data to the delivery of healthcare and we had point of service collection of data. Well, I think it would be a lot easier, quite frankly, to give patients a smartphone and they collect their own data on their own biometric smartphone and dock in with a doctor every time they attend a clinic or see somebody. So the next important principle is that one needs to front load the service with the expert. And as a consultant, I regard myself as the expert in my service, but I'm dependent on a lot of other people around me to support that being done. But I introduced a Fit to Admit clinic in 2003, which effectively rubber stamps all elective admissions prior to cardiac surgery. And I can demonstrate that I'm saving £140,000 a year because I have patients who have been provided a script of what to expect, a discharge date, and I have screened out all potential medical problems prior to the patient actually coming to the ward. In fact, I don't admit patients for elective surgery unless we have an agreed discharge date and the patient has actually satisfied themselves that they have sorted out their social care and support at home. Of course, if clinically necessary, we bring the patient in for an operation. Simply doing this has actually reduced my length of stay, my readmission rate is lower, and my patients get up and move and usually discharge day 4 or 5 following cardiac surgery. Why? Because the whole process has been front-loaded with an expert. I've given them a script on what to expect, and we've agreed a discharge date. The next important principle in the delivery of healthcare is to get rid of all the things that we attribute to because we've always done it that way around here. And I reflect on my experience with seeing follow-up patients, and we always organized a chest x-ray. Well, a registrar of mine did an audit over a year to find out how many chest x-rays were abnormal during that period. 13 throughout the year. So the following year, we stopped doing the chest x-rays and were only sending patients for a chest x-ray if it was clinically indicated. Simply doing this is saving another £26,000 a year, but it has also improved the flow of the patient through the system. There are no waits. What is interesting, when I introduced this, the outpatient clerk challenged me and said, well, I don't think it's working well because the patients are waiting a long time. I invited her to redesign the template as she felt fit, because Angela could see the patients waiting and knew how to actually schedule. I'm in the office. I can't see that. So I left it to Angela to sort out. Suffice to say, not only have we improved the throughput of patients through the system, we have reduced the waits and delays, but I'm also asking patients for feedback. Because in a service system, unless you're asking for feedback, you'll never know how to improve. But in that regard, you don't include anything less than 5 out of 5 satisfaction. And I'm delighted that I am running at a 90% 5 out of 5 patient satisfaction. What's interesting, having stopped the chest x-rays, some of my colleagues said that I was opening myself up to litigation because patients were expecting chest x-rays and coming to clinic. Well, I did point out to them that my examination is thorough, and I include inspection, palpation, percussion, auscultation on every patient, front and back, and I document in the notes, chest x-ray is not clinically indicated. I don't see the problem. And it leads me to the second thought. I think we are over-investigating everybody in the NHS. I know my post-op patient gets bled every day because that's the way it's done around here. And there was a paper that suggested that some post-op cardiac patients lose 2 pints of blood in the post-op period. Why? All our investigations should be done following a proper history and examination. And I worry. I worry because we've reduced history and examination to tick box clerking. Ticking boxes without listening to a patient's story. Taking a proper history and listening to the patient does not cost a lot and does not take a lot of time. But having taken a proper history and then directing your investigations, we can save a lot of money. Not only that, we'll improve the service and improve the patient experience. Simple, really. It may take a little bit more time, but I think it's safer, it's better for the patient, and it's better for the doctor. In that regard, I'd go further to suggest that as clinicians in the health service, it is time that we start defining clinical speed limits, where if you rush, mistakes are going to happen. If you're in charge of too many patients and your attention is diverted, mistakes are going to happen. We have a duty of care. We have a duty of service. But in our business, that service also demands that we adhere to speed limits. It'll be good for training, it'll be good for staff, and it'll be good for everybody. This is my simple recipe for the NHS. Doesn't cost any money, and my change I made to my clinic didn't cost anything at all. For me, it is a simple change in mindset and a simple change in thinking. And that's why I have the eponym "You Can" on my Twitter feed. Because if I can save £166,000 a year with a simple cost-neutral change in thinking, imagine how much money the NHS could save if every clinician in the country applied the same thinking. Now there's a challenge. Thank you.